Mental status assessment. So as part of this chapter, we're going to talk about the behaviors that are used to assess mental status. We'll talk about developmental care related to the examination and what we expect to find in the different developmental stages, infants, children, aging adults. We'll talk about the purpose of a mental status exam, the 4 components, and we'll go into some detail on those components. And as part of your lab this week, you'll complete a mini mental state examination. So first we're going to start off with some definitions. Mental status has 2 parts. One is how the person is feeling, their emotions. Are they anxious? Are they depressed? And then there's also a cognitive part. Are they able to think logically? Are they able to problem solve? And those go together to make up mental status. I also want to define mental disorder, and that's when a patient, they might have a traumatic life event, or there may not be a trauma, but their response to the situation they're in is greater than expected, and it results in significant ongoing changes. This patient is going to experience significant distress. They may have trouble functioning in the social realm, in the occupational realm. They may have difficulty at their job because of these symptoms and their inability to function. Mental disorders are classified in 2 ways. We can have an organic disorder, which means there's a disease that is readily identifiable, a brain tumor, something that we can, alcohol and drug intoxication is another thing that has a definite cause that we can pinpoint and deal with. And then the other type is psychiatric mental illness, where we don't have the exact cause. We know some of the things that occur in mental illness in terms of changes in the brain and brain chemistry, but we can't pinpoint the specific cause like we can with an organic disorder. Mental status is inferred, and that means that we can't use our stethoscope or use our eyes or listen or feel someone's mental status. We really have to look at their behavior, and based on their behavior, assess their mental status. And so these are the components of mental status. These are the things that are assessed. One of the things that assesses these categories is the mini mental state exam, which you'll do in lab. And these are all defined in the text, and I would take some time just to read those definitions so you know what they mean. Okay, and then in terms of developmental competence, infants and children, they're still developing neurologically, and so it's often difficult to get their mental status, to assess their mental status. Newborns start off with reflex behaviors, and then as they mature neurologically, they're able to, in elementary school, late elementary school, start to think through problems and have more abstract thinking. Little children are very realistic. They're very, what they see is what's real, and they don't really think about abstract concepts like love and other, abstract things. They're very stuck in the real world. With an older adult, we do have to be careful because things like vision and hearing loss can make it look like an older adult is having trouble with their mental status, and really it's just a difference. Maybe they can't hear or see the stimuli that you're offering, or if you're asking questions and they can't hear what you're saying, then their responses are not going to be appropriate. Also understand that it may take them longer to respond to questions. We may see a decrease in their recent memory. Older adults tend to have good memories of early life, but recent memory may be affected. So the components of the mental status examination are listed here. We abbreviate them A, B, C, T. And I'll go into more detail about what is included in each of those components. But I want to make this point that normally we do not do a separate assessment of the mental status. Usually as we're talking to a patient, we're gathering all this data about their appearance, about their behavior, about how they think. And does it make sense to the interviewer or the nurse? So mental status is not usually something that we do separately unless there's a good reason. So these are some times that we would want to perform a full mental status exam, something like the mini mental state examination that we'll do in lab. So while we're talking to the patient, maybe there's some screening questions about anxiety or depression, and they get a score that indicates that those might be present. Maybe they're having behavior changes. Maybe they have an organic disorder, a tumor in the brain, a stroke, and we know that those patients are more likely to have changes to their mental status. A patient that has aphasia, we're going to have to do a full mental status exam, and then someone that is experiencing symptoms of mental illness. So the objective data that we're going to gather are, first we want to start with the most basic functions. So is the patient conscious? And then their ability to use language. If they speak a different language, it's going to be really difficult to get to the bottom of a lot of these components of the mental status exam, because these are very abstract concepts. And so if they're unable to speak, or they speak a different language, if there are issues with their level of consciousness, if they're drowsy or in a coma, obviously we can't proceed with the mental status examination. You also always want to make sure that you know about any sensory or perceptual deficits that the patient has. Do they wear a hearing aid? Do they need glasses? Are there problems with their vision? And that's especially important in the elderly. Also, in some cases, we may delay the mental status exam if a patient is intoxicated, if they're not fully conscious, or they're having trouble speaking, and we expect that will resolve, then this can definitely be deferred until later, because we really want to get the best results. We want the patient to be awake and able to communicate well for this assessment. So here are the components of appearance, and that's basically, what are we seeing in their appearance, their posture? Are they sitting up straight? Are they slumped? Their dress, is it appropriate for the weather? Is it appropriate? Their grooming, are they well groomed, or are they not taking care of themselves? Sometimes with depression, we see a big change in hygiene. Their behavior, that starts with level of consciousness, and there's a table that I'll discuss towards the end of this chapter that talks about that. Their speech, the words that they're saying, are they appropriate? Are we, or do they make sense even? In some cases, some mental illnesses, the words don't make sense. Their mood, which is a prolonged expression of their feelings, and their affect, which is a temporary show of feelings. Okay, we also want to think about their cognitive functions. Are they oriented? Do they know their name, where they are, what month it is? Are they able to pay attention to what we're talking about, or are they kind of off in another world? They keep going back and forth. Their recent memory, can they remember things that we talked about at the beginning of the interview? Their remote memory, things that are further back in time. We can do a 4 unrelated words test that deals with recent memory. And then the book talks about some additional testing for people that have aphasia. And aphasia means they're unable to speak. They're unable to communicate. Okay, we also want to look at their thought processes, their perceptions. From their conversation, does it make sense, the things that they're thinking? Do they have compulsions or obsessions, things that they have to do? In some mental illnesses, there's a compulsion to wash your hands a certain amount of times. Um, their perceptions, are they congruent with yours? Are they seeing things that are not present? We also want to do some screening as part of this exam for anxiety and depression. And there's some tables in your book that have some screening questions for those mental illnesses. And then we always want to screen for suicidal thoughts anytime we're dealing with mental status. Understand that you may be the only person that picks up someone's clues about wanting to commit suicide. We can ask them if they feel like harming themselves or harming others, if they have a plan. All of those are important in screening for suicide risk. And then we want to assess their judgment. Judgment is, are they able to look at two alternatives, evaluate those alternatives, and reach an appropriate course of action? And so, you could ask them about something in the future or a decision that they've made, their future plans, and those should all be realistic. Okay, so the mini mental state examination, which we're going to do in lab, addresses these categories, and so you'll see that when we go through it. Lastly, we are going to do mental status assessment different based on the child's age. With infants and children, we really just look at how do they deal with their environment, do they meet their developmental milestones, do we see the behaviors that are appropriate for their age, and that is a good indicator of mental status. With the aging adult, it is so important that we check their sensory perception because you're going to get a poor result on their mental status if they have a vision or hearing deficit and you're not picking up on that. If you're trying to assess their mental status, they're going to have a difficult time understanding the questions and talking about abstract ideas if they can't hear or they can't see well. In the book, it does talk about some additional changes in assessment of behavior and cognition for the older adult. And then there's a specific test called the mini-cog that's used with delirium, which is a temporary change in mental status, and there's usually an identifiable cause that can be reversed. Okay, levels of consciousness. This is really important. You're going to use this over and over and over on all your patients. We usually assess the level of consciousness, and so I would recommend that you maybe make flashcards or just really understand these 5, 1, 2, 3, 4, 5 alert through coma levels of consciousness, and then also that you understand what delirium is. Usually delirium is something acute. It happens very quickly, often when an older adult is admitted to the hospital or they're given pain medicine. It very quickly can lead to a temporary change in behavior that once the cause is identified and treated, the delirium usually goes away. Also, you should be aware of the Glasgow Coma Scale, which is a very common tool that's used to measure level of consciousness. Table 5.2 lists some speech disorders, and it would be good if you knew the definitions of these words, but that's about as far as you need to go with that.